Okay, this is regarding a patient that was seen yesterday, 411. He's a 97-year-old male, was seen today for a follow-up. Blood sugar was taken in the morning at 5:29 and was 59. Then patient was scheduled for the OR at 1:30 for dorsal slit. And fasting sugar was rechecked again at a little after 8 o'clock, and this was after he was given 2 cups of apple juice. Past medical history, just to name a few: hypercholesterolemia, proteinuria, dementia, hypertension, diabetic retinopathy, chronic pancreatitis, CKD stage 4, BPH, frailty, hip fracture, anemia, diabetes, anxiety, and urinary incontinence. He does have allergies to penicillin. So review his systems. Denies any chills or loss of appetite. Patient was NPO after midnight and was given his sliding scale, which I'll get into later on. But general denies chills, loss of appetite. Respiratory denies shortness of breath with any difficulties breathing or any pain with inhalation or exhalation. Denies any chest pain, denies abdominal pain, nausea, vomiting, or diarrhea. Neuro denies headache or numbness or tingling. And psychiatric, no changes in mood or behavior. And this was during the time when we were doing our assessment. So upon physical exam, veteran, he is an elderly male showing no signs of acute distress. The patient is alert and oriented to self and place, which is his baseline. We basically brought him in his wheelchair into the office to do his assessment. Respiratory, his lungs were clear to auscultation. There was no adventitious sounds. CV, heart sounds, S1, S2 present, and apical pulse was within normal limits. GI, no abdominal distension. Belly was soft and non-tender, flat. Bowel sounds were present. Neuro, baseline for patient, no changes in upper or lower strength, and his affect was flat. Not aware of his physical limitations, but that's kind of his baseline. So after discussing further, because while Pat was away, there was a change in his sliding scale, and an additional sliding scale was put on at nighttime. So instead of having 3, which was his usual, there was now 4. So we discussed this, and she asked me what I would recommend, and I would say I would definitely recommend checking his sugar, considering this was roughly around, I think this was early in the morning, so by the time we got to him, this was like around 9 o'clock or maybe a little bit before. So she put in orders to check his sugars every 2 hours, because she did try to push up his surgical time because he's NPO and she had already given him juice. So they didn't want to continue giving any more fluids or anything PO, considering now you're pushing closer to the time where he's going to be sedated for his surgery. So I said, well, I would definitely let them know, because ideally before sedating him, once he has IV access, push an amp so that way he's covered, and then they can recheck sugars once he comes back to the floor, or even after surgery, just to ensure that he hasn't had a dip in his sugars. The patient's able to eat as well. So once he's done his surgery, he can come back, and as long as his sugar's fine, then they can recontinue the regime as far as giving his sliding scale and so forth while he's actually eating. So it was discussed with the GUPA about the hypoglycemia to see if the surgical team can move up his time. It was not, unfortunately. And then the amended sliding scale for Aspart was removed for bedtime coverage for prevention of AM hypoglycemia. The patient ended up actually going to the OR for 11:30, which was nice. His sugar did drop again at 10:08. It went down to 69. So it was a good learning point to know that you can actually give like the liquid glucose, and that it would not affect as far as him going for surgery. But again, this would be something that would be discussed with people with the anesthesia team to, if I was working in a place where this would be something that would happen. But it's good to know. It was a good educational point as far as if, a patient is going for surgery, what other avenues we can use if we don't have availability of IV access. That was also considered as far as considering where the patient is at. They can get an IV team in and do it themselves. That was also discussed, and possibly starting the patient on a drip for sugar support. But by the time everything had been discussed, surgery, were able to take him sooner rather than later. So it was a good brainstorming position where my ER came into play, and as far as rechecking sugars and following up. So it was a good patient to work with. Thank you.